fit in your pockets. Now let's study today's topic, it is benign prostatic hyperplasia and prostate carcinoma, in which we see the first normal anatomy of the prostate. The weight of prostate gland is 20 grams and it surrounds the male urethra. Here, urethra, prostate and urinary bladder. There are 5 lobes in the prostate: anterior lobe, middle lobe, posterior lobe and 2 lateral lobes. Here in sagittal section we see anterior lobe, middle lobe and posterior lobes. There are 3 zones present in the prostate, that is transitional zone, peripheral zone and central zone. And the histology of normal prostate is glandular epithelium consists of 2 layers: a basal layer of low cuboidal cells and an inner layer of mucus secreting tall columnar cells. It has fibromuscular stroma and the glands secrete corpora amylaceae to the lumen. Common in older men. It is a laminated, rounded, secretory concentration and it is eosinophilic in nature. Benign prostatic hyperplasia is a non-cancerous enlargement of the prostate gland that commonly affect older men. Enlarged prostate compress urethra and interferes with the normal urine outflow. It is more frequent in men more than 50 years of age. Its incidence is 80% of men above 80 years. Its sites arises from transitional zone or the middle lobe, and its causes are enzyme type 2 5-alpha reductase located in the stromal cells convert testosterone to dihydrotestosterone, and dihydrotestosterone moves through epithelial cells and bind to the nuclear androgenic receptor in both stromal and epithelial prostate cells that stimulates the transcription of androgen-dependent genes, and growth factor is released and their receptors are formed, which leads to increase in the size of stromal and epithelial cells that leads to prostatic hyperplasia, which leads to benign prostatic hyperplasia. Now the gross features of benign prostatic hyperplasia are enlarged prostate, nodular, smooth and firm in appearance, weight 60 to 100 grams. Clinical features is firm and cut section is firm and homogeneous. Multiple well-circumscribed nodules of varying sizes, and nodules are grey-white in appearance. The microscopic features are glandular hyperplasia, exaggerated intra-acinar papillary infoldings with deficient fibrovascular cores. Lining epithelium is 2-layered, inner tall columnar mucus secreting with poorly defined borders, and outer cuboidal epithelium with basal nuclei. And the fibromuscular stroma show hyperplasia, aggregation of spindle cells. In the diagram, we see the papillary infoldings, corpora amylaceae, and the fibromuscular stroma. Now, the symptoms of benign prostatic hyperplasia are frequent urination, especially at night, nocturia, urgency to urinate, difficulty in starting urination, and dripping at the end of urination. The risk factors are age more than 50 years, family history of benign prostatic hyperplasia, obesity, diabetes, lack of exercise, and the treatment is tamsulosin, which is an alpha blocker. Prostate carcinoma is a malignant epithelial tumors arising from the glandular epithelium. It is the second most common cancer in males and it is most common in lung. It also occurs in men more than 50 years of age. Its incidence is more than 50% men of 80 years age have asymptomatic prostatic carcinoma. Its site is peripheral zone and it is mostly asymptomatic because it arrives from the peripheral zone, so it takes time to reach the urethra and obstruct it and reveal the symptoms. Now the risk factors are age more than 50 years, family history of prostate carcinoma, high fat diet, androgen stimulation and genetic mutation of BRCA2 and HOXBI3. Now the gross appearance of prostate carcinoma are prostate appear hard, irregular and enlarged in size. Cut sections show homogeneous and contain irregular yellowish area and gritty in appearance. The microscopic features of prostate carcinoma are loss of intra-acinar papillary convulsions. Acini are closely packed in back-to-back arrangements without intervening the stroma, and glands are lined by a single layer of cuboidal cells, and malignant acini have little or no stroma between them. Perineural invasion is seen, and clinical features are early asymptomatic, later stages difficulty in urination, hematuria, nocturia, and increase the frequency of urination. Spreading of the prostate carcinoma. Direct spread extend into the bladder's neck, seminal vesicles, and trizone and urethral opening. Lymphatic spread to sacral, iliac, and para-aortic lymph node. Hematogenous spread to osteoblastic, osseous, metastases and especially to pelvis and lumbar spine that leads to lower back pain in prostate carcinoma patients. Other sites are lung, kidney, breast and brain. Tumor markers are prostatic acid phosphatase and prostate specific antigens for prostate carcinoma. In other investigations or diagnosis are tumor markers, MRI and needle biopsy. Complications of prostate carcinoma are urinary obstruction, hematuria and urinary retention. Now, the grading system for prostate carcinoma is Gleason grading system, which is the basic glandular architecture pattern is used as the basis in which the tumor contains more than one pattern. Primary grade is dominant pattern, which is the most common pattern seen, and secondary grade subdominant pattern or second most common pattern seen. Now we can see both primary and secondary architectural patterns are graded from 1 to 5, with 1 being most differentiated and 5th being undifferentiated. Gleason score is derived by addition of these two grades. Now the grades and the histological features. Grade 1 is small, uniform, well circumscribed glands are seen. In grade 2, glands are more loosely arranged with minimum infiltration. In grade 3, individual or well formed infiltration glands are present, which is a low grade cancer. In grade 4, fused or poorly formed or cribriform glands are seen, and in grade 5, no gland formation is seen. Solid sheet cords or single cells with marked atypia and necrosis is present. For example, in a slide we see primary grade, in which we see more third grade carcinoma, so we will write 3, and second most common we see second grade carcinoma. The total is 5, so it is a low risk or low grade carcinoma. This Gleason scoring is come by addition of primary and secondary grade. Now, if for primary grade is 3 and secondary grade is 4, then total is 7, which is an intermediate carcinoma. And if the primary grade is 5 and secondary grade is 4, then total 9, so it is a high risk grade carcinoma. And if we given 3 values, then those values will be chosen which has a higher value. For example, the primary grade is 5, secondary grade another is 2, and another is we will see 3. So in both primary is considered, and for secondary we have 2 options, so we will choose which is the greater number, that is 3. So 5 plus 3 is seen, which is equals to 8. So it is intermediate grading. Now the difference between benign prostatic hyperplasia and prostate carcinoma. It is benign in nature and it is malignant in nature. It arises from transitional zone, it arises from peripheral zone. It has a smooth nodular enlargement, it has a hard irregular infiltrating mass, and it is intact and it invades the stroma. It has hyperplasia of gland and stroma seen, and it are malignant glands with absent basal cells. And here metastasis absent, here present, and here mild elevation is seen and the marked elevation is seen. Now the Gleason grading, in which we see the normal prostate epithelium, in which we see the primary or grade 1, grade 2, grade 3, grade 4 and the grade 5 infiltration is markedly seen. Here we see the histology of prostate carcinoma, in which the perineural invasion means the cells invade the nerve cells, and here the back-to-back glanding is seen, and loss of convergence and loss of fibrous tissue is also seen. Fibromuscular stroma is lost, so it is now prostate carcinoma histological features. Now that's all for today's videos. Thank you. Follow for more such videos.